I'm Shazli Azmi, I'm a consultant diabetologist and I work at Manchester University Foundation Trust. Diabetic retinopathy is a microvascular complication of diabetes. Other microvascular complications include neuropathy and nephropathy. So in particular, what happens when you get microvascular disease, you get inflammatory mediators that are released, and this will in turn affect the vessels of the eye, leading to diabetic retinopathy. I suppose that's more of a simplified version. You'll get, with the ischemic drive, you get production of VEGF, which eventually can lead to neovascularization. This similar process obviously is happening in other microvascular complications as well, and one of the main things that we need to do is try and control this earlier. We do need to take this into consideration when managing patients with diabetes. It's really important. One of the mainstays of treatment is trying to prevent these patients from getting complications later on. The way we do it from a diabetologist point of view is obviously control blood glucose, which is probably one of the most important things. But we're not just limited to blood glucose, there's other things as well. So we know that cholesterol plays a big role, hypertension, and quite a lot of metabolic risk factors. So all of them need to be controlled in order to reduce the risk of microvascular complications, such as diabetic eye disease progressing. So the biggest barrier to early intervention, difficulties, there's lots of barriers. So I suppose the biggest one is lack of resource, I would say, both from a diabetologist point of view and an ophthalmologist point of view. Certainly we are identifying more and more patients with diabetes. However, there is a big volume of patients that are not identified, and this kind of brings about the fact that actually the patients with pre-diabetes, they also are being exposed to the metabolic factors, so they'll also develop microvascular complications, and those patients aren't screened, and in fact there's more of a drive now to identify those patients so that we can pick them up early and give them lifestyle factors and treat what we can so that they don't actually develop diabetes, let alone the complications from that. However, when someone is diagnosed with diabetes, in particular type 2, we do find that they actually already have some of them will already have microvascular complications. So from a resource point of view, we need to try and get these patients early. However, if we start the more we focus on this early group, it's a phenomenal number. How are we ever going to capture that many? There's more and more work being done to try and identify patients earlier, and then in particular once they are diagnosed, we've got the retinal screening program, which is fantastic, and the uptake of that is quite good. We only have to look at other places such as I suppose the USA and Australia, where they don't have diabetic eye screening, and the results that they have from retinopathy are obviously far worse than what we have in the UK. So resource is a big problem. Once somebody is diagnosed, once somebody is identified as having a problem, so if they've got proliferative retinopathy or they've got macular edema, the time to treatment after that is a big issue as well, and that comes down to the ophthalmologist resource. So they may identify it, however it may be a good sort of 6 weeks before they even go on to be having treatment. The other barriers to that are, I suppose, patient education, patient compliance. What does retinopathy mean to the patient? I think is quite important. We often talk about the fact that they will get microvascular damage, but what does the patient interpret from that? It's easier to tell someone, if you don't control this, you will get a heart attack, you'll get a stroke. That's a bit more relatable from what they understand. But when we use words terms such as retinopathy, they may not fully understand that actually retinopathy, if this is untreated, that can lead to blindness. So this is the importance of you attending the screening program annually, and this is for your benefit. If we had enough people to look after patients and identify it earlier, then obviously it would get better. But by any means, in the UK at the moment with the retinal screening program, we are doing well at actually picking up retinopathy. It's just the volume of patients is increasing, and that's going to place more of a burden on the actual retinopathy screening service. From a diabetes point of view, we see a lot of people with diabetic eye disease, and I suppose one of the things that might improve things is integrated care between the diabetologist and the ophthalmologist. I think that's paramount. As mentioned previously, we have actually, with our other microvascular complications, we have got integrated services. So we do have joint renal clinics, we've got foot clinics where podiatrists and the vascular team will come. However, we don't have that with ophthalmology. They tend to be sort of two distinct entities, and I think integrating these somewhat will improve the care and the outlook for patients who have diabetic eye disease. As an example, so somebody who is having monthly VEGF injections, that's a fantastic point where that patient is coming to a clinic. If we had a diabetic nurse that popped into that clinic and had a look at the blood glucose, and even sort of they could have a look at the blood tests and have some feedback to the GP or to ourselves depending on where the patient was followed up, that would be fantastic, because you've actually got trying to get the patient to you is one of the biggest barriers. And actually, if you've got somebody coming regularly to a clinic, why not use the opportunity to feed in both specialties. I know that certainly they are using diabetic nurses within the ophthalmology department, and I think that would be a fantastic tool if we use that wider to actually improve outcomes for those patients, because at the end of the day, once you've got the eye disease, you can obviously, for retinopathy they can have laser treatment, but then the idea is you want to stop it from happening again, and the way to do that is obviously controlling the metabolic factors. So integrated services between both would definitely sort of improve things, and also it would upskill, sort of from a diabetologist point of view, it would upskill what we need to know about managing diabetic eye disease, and picking up patients earlier, so that actually, well, this patient has it now, so now this patient has been treated, so let's try and make sure that this doesn't happen again, so that their future is brighter.